Thank you. So good morning, everyone. Thank you for that introduction. We've got a very interesting session on physiology today, just making you think about a really common topic, which is angina, which we see a lot of patients with angina, but perhaps we don't think of their problems in quite the right way. And probably the first thing to say is that every patient is an individual, and they have angina can be a common manifestation of symptoms, but the pathophysiology underlying angina is often very different. So let's think about our current assumptions about ischemia. We think ischemia means bad outcomes, and that may not be the case. We also think ischemia equates to angina, where in fact there is an overlap, but they're not the same. As interventional cardiologists, we also have this very strong belief that angina is caused by obstructive coronary disease, and we know they're not. And we've also got these binary cutoffs, which are driven by academic cardiology, in particular IFR, FFR, etc., which are used for diagnoses, which may not translate to what the patient feels. We also believe, and of course many conferences are built around this particular hypothesis, that outcomes will track improvements in ischemia. So let's ask the question, are angina and ischemia synonymous? We kind of think they are, and there's certainly a big overlap between the two, but frequently we're confronted by patients with non-typical angina who may have breathlessness, who may have fatigue on exertion. We're also confronted by patients who seem to have a lot of ischemia, but almost no symptoms, so they seem to be able to go running or have a completely normal life despite having an alarming burden of ischemia. So let's drill down into this a little bit further and ask the question, what is angina? And what is ischemia? And what should we understand about the two? So ischemia is actually pretty easy to understand. It's a supply-demand mismatch. When I'm explaining this to patients, I give them the analogy of a steam engine with coal, and your steam engine requires a certain amount of energy, and when the train is at the station, it doesn't require a lot of energy, but when it's going up a hill or it's going at high speed, it requires a lot of coal, and coal being the analogy for oxygen in this case. And you can see that this is a supply-demand mismatch. Many things can increase demand in terms of your heart rate, obviously, which you get on exertion, but contractility, afterload, and so on. And the supply is, again, a number of things like epicardial flow, which is coronary patency, but also the degree of energy that the muscle requires, which is affected by things like the microvascular resistance and diastolic pressure. And we understand this paradigm very easily, where flow is quantified by this calculation between pressure and resistance. We look at a coronary stenosis and we think, okay, that will translate to a certain amount of flow resistance. We also understand the principle that as resistance increases, there's a compensatory situation that comes in with the microcirculation. So if you look at the resistance in the microcirculation, it decreases as the resistance in the epicardial situation increases. And that is such a profound compensatory mechanism that it can maintain flow with all but the most critical stenoses. Clearly it has limits, but most of the time those limits aren't exceeded in normal stable coronary artery disease because of the degree that the microcirculation can respond to those changes in epicardial resistance. So we get to this point where flow is impeded, but then you're really looking at an absolutely critical stenosis. But remember, this isn't a problem necessarily of what the artery looks like. The myocyte is completely agnostic to this. It just needs to understand, can I get the same amount of energy in response to demand? And that, of course, can also occur in the context of a dysfunctional microcirculation. And that's where the principle of coronary flow reserve comes in. And that's a very simple concept that says, can I respond to demand? We know that demand can go up to 5 times. When you exercise, the flow should increase about 5 times. And the microcirculation isn't able to to correspond to that demand, you're going to get the same ischemia that you would in the context of epicardial stenosis. And you can sort of think of the microcirculation like a sponge. It almost creates a vacuum effect and sucks the blood where it needs to go. So if we spill something on a table, before we mop it up, we squeeze the sponge. That's the contractility of the myocardium. And then we relax the sponge when it's on the liquid. And that relaxation effect sucks the liquid into the sponge. And that's kind of what the heart is doing. It's kind of creating a negative vacuum effect and sucking the blood where it needs to go. But sometimes that doesn't work very well. So for example, if you have a stiff heart, it's unable to create the same vacuum effect, and therefore there'll be a higher resistance to flow. But on a patient level, the outcome is very similar. So you look at these two scans, you'd say the scan on the right with a relatively low burden of ischemia, and the scan on the right with a very high burden of ischemia, you'd say, well, that man or lady will have a critical left main, but actually this is non-obstructive coronary disease with a very high ischemic burden. And then we've kind of gone back to the future with this. We've been told over the years that exercise tolerance testing is not very sensitive for detecting myocardial ischemia because we get these false positives. But actually recent data has shown us, actually, we're not asking the right question. What we're using an exercise test to do is detect epicardial stenosis. And yes, it has low sensitivity for that. But when you look at, does it detect ischemia? And does that ischemia matter to patients? Is actually pretty accurate. And it tells you other information like how far can the patient walk and indirectly what their VO2 max may be as well. Remember, ischemia is essentially a myocyte disorder, and we consider it as an epicardial disease, which is not the right paradigm. So the question we often should be asking is, what is angina in your patient? And there are several options. We've got the thing we feel very comfortable about, and that's epicardial disease. But also spasm is a significant component in some patients. And then we've got microvascular disease, which we're learning more and more about as we progress. But remember, if there is ischemia, this is occurring at the myocyte level. And then, how does ischemia translate to angina? There are complex neural pathways which involve, obviously, the brain, but also the nervous system and the spinal cord. And finally, there's a social overlay in terms of how those symptoms are interpreted. And there does seem to be a relationship between the degree of ischemia and the typicality of the symptoms. I'm not really sure what happened there. Maybe they're telling me to shut up. Is that what they're doing? Or they're thanking me for my efforts? I'm nearly finished, honestly.
How long did it?
Yeah, 2 minutes. I'm just telling what he wants to hear here. Very good, thank you. So this does come down to goals, expectations, and treatment. And if we want to be good clinicians, we need to align to patient-level goals. That means understanding their problem. It means tailoring the therapy according to their need, whether that be tablets or revascularization or surgery. And understanding what their expectations are so that we define their goals in terms of, their lifestyle. And that means making an accurate diagnosis, and therefore the diagnosis should align with how well we can predict their response to treatment. So Carlos is going to talk on PPG, so I'm not going to labor that point. And then it comes down to what our treatment options are. And our paradigms currently are medication, which is prognostic as well as symptomatic, revascularization, but we're broadening those implications to include things like the coronary sinus reducer, which is showing some very interesting data, the placebo effect, how our interaction with the patient influences their outcomes, and some more novel therapies such as drug-coated balloons or the bioadapter stent, which is under investigation currently. So to be a good clinician for your patient, you need to define the mechanism of angina. You need to understand how that will predict the outcome. And you need to align that to the patient's expectations. Thank you very much for your attention.